Yeah, sorry. I think today there is some problem with the network. Every time I'm coming live, it is taking me again. So I was saying that guys, while we are discussing the questions, you are feel free to post any question related to that quiz or any other thing, because when I am already describing you anything, it becomes easier for me on the board. So if there is anything that you want me to describe, or there's any doubt, then other than the quiz also, please let me know, post it on the live chat, so that I get to know what are your confusions and the doubts related to it, because I don't want any doubt should remain now. Two important papers are coming. We have INI paper, and again I'll say that please read the instruments very carefully today. Look at the instrument video also, and the today's video and today's quiz is definitely going to help you in the upcoming exams, because they are asking many more questions about the practical aspect, so that definitely consists of your instruments. Post refractive surgery management, so we will be taking it someday. Otherwise, on the refractive surgery, the whole of the video has been already posted, all the types of refractive surgeries. And if you want to deal about the management after the refractive surgery, so that I'll definitely take in a separate video, right? Any other thing? Please keep on telling me what are the things that you require, because when I am in a uh, uh, in a mood of preparing the video, so I have that in mind, that yes, I can go with this topic, I can go with that topic, so something like this. So we'll start with the quiz questions. So if you see, this is your very first question, and I think this we have already discussed the other day in the gaze palsy also. If you look here, if you look here, so this is your baseline, so both of them are in the center, right? Now this is your right eye and this is the left eye, so this is your right gaze. Good afternoon, Abhishek. This is your right gaze. We are dealing with the quiz questions of abnormal pupillary reactions. So in the right gaze, both the movements are normal. This eye is adducting and this eye is abducting, right? Both of them are normal. Now if you look here, when the eyes are looking this way, so this is your left gaze. When the eyes are looking in the left gaze, there is a problem. So this eye is not have got the left gaze abduction nystagmus. That is why our answer will be what? Sorry, it's not right. This my answer will be the right MLF, because this is your internuclear ophthalmoplegia, in which we have ipsilateral adduction deficit and we have contralateral abduction nystagmus, that is there. Then coming to question number 2, the given image is related to. So look at here, when you are not showing any light, this is a normal size of the pupil. So this is your normal size of the pupils, you can see here. Now here we have got, they are saying there is a normal response to the light. So can you see, we have the pupils constricted. So this is your right eye. So this is your right eye, this is your left eye. When I am showing the light to the left eye, direct is present, direct light reflex present, it is constricted, and this is also constricted. So indirect light reflex is also present, both of them are there, right? But when I am showing the light to the right eye, there is no response here also, no response here also. So this is what is called as the RAPD, which is also known as the Marcus gun pupil. So answer is Marcus gun pupil. Next question, a patient seeks ophthalmological evaluation because he says that eyes are not looking right. Just a second guys, let me connect to Wi-Fi. It's much better now. So they say that eyes are not looking right, and the important thing is that the more anisocoria is present in the dark than in the light. So where do you get more anisocoria? In the dark. When you get more in the dark, this is your Horner syndrome. More anisocoria in the dark means you are having Horner syndrome. So you have to see the statements according to the Horner syndrome. So let us see what are the statements. Number one, neither pupil should constrict to pilocarpine, because in the Horner syndrome you have got the dilator pupillae palsy due to the sympathetic palsy. So obviously this is true. Then the right pupil would dilate poorly after cocaine. Yes, now this is also true, because you have got two tests. One test is your 1% epreclonidine. There are two tests that I can use for the Horner syndrome. One is your 1% epreclonidine, or we can use 4% cocaine also. So we have got two tests. Now epreclonidine is positive in the Horner syndrome, while cocaine test, it is negative in the Horner syndrome, negative. So that means right pupil will dilate poorly after the cocaine instillation. This is also true. The presence of the right abduction deficit would localize the lesion to right cavernous sinus. Yes, right cavernous sinus will have the right sixth nerve palsy, and the right sixth nerve palsy will lead to the right abduction deficit. So answer to this question is the responsible lesion interrupting the neural impulse, as the neurons synapse in the ganglion. So they are not synapsing, no synapse, they are only passing, there is no synapse. Next question hai, you see a patient in the ICU after the cardiac bypass surgery, his right eye is dilated. Then we are doing a swinging test light, swinging light reflex test, and we know that this test is done for a RAPD. So what would be observed if he has a right afferent pupillary defect? If I have a right afferent pupillary defect, what will happen? That means, suppose this is the eye here. Now this is your right eye and this is your left eye. So when I am showing the light to the left eye, I will get the direct light reflex also, and in the right eye I will get the indirect light reflex also, right? But when I switch this to right eye, I will not get direct also, I will not get indirect also. Therefore answer is, when the light shines on the right eye, left will dilate. Even right will dilate, left will also dilate. So this is your RAPD. Question number 5 hai, we have a black woman noticed a change in the vision, and the visual acuity is 20/20 and 20/200. Now always remember that OD is your right eye and OS is your left eye. So left eye में 20/200, that is 6/60 है, and right eye में 20/20, that means 6/6 vision है. Now there is a left afferent pupillary defect. So left eye में 6/60 with a afferent pupillary defect है, and we have a swollen optic nerve head also. That means we are very clear that we have something related to the optic neuropathy. We have optic neuropathy, and in which eye we have the optic neuropathy? In the left eye we have a optic neuropathy, RAPD भी है. So what is least helpful in the historical factor? So one is your hyperthyroidism. Hyperthyroidism, recent 1 month episode of left arm numbness. This could be present in the multiple sclerosis. This could be present in the multiple sclerosis, which is the most common cause of the optic neuritis. Then if you see the other one, the hilar lymphadenopathy. Hilar lymphadenopathy means we have got the sarcoidosis. We have got the sarcoidosis. This can also lead to the optic neuropathy. Then we have got the hypertension. Hypertension can lead to anterior ischemic optic neuropathy. So what is least useful? The least useful is your hyperthyroidism, because hyperthyroidism will mainly lead to the lid retraction. What is the most common sign that you get in hyperthyroidism? We get lid retraction, we get proptosis, and then in very late stages I get the compression of the optic nerve. Then I get the compression of the optic nerve, that will be called as the compressive optic neuropathy. So this is in the very later stages. That is why this is least useful. Hyperthyroidism is least useful therefore. Then coming to the question number 6 now. In homozygous pupil, all are true except that most cases are bilateral, because this is the most important thing in the Aries tonic pupil, that 80% of the cases are unilateral. 80% of the cases are unilateral in the Aries tonic pupil. And we have got in the Aries tonic pupil, what is found? We have got the light reflex absent, and accommodation reflex is also absent, or it's very, very slow or sluggish. So we have absent or retarded pupillary light reflex both to the light and near. It causes reduced accommodation also, reduced reaction also. It can constrict with 2.5% methacholine, or it can constrict with 0.1 to 5% pilocarpine, because it has a denervation sensitivity. Because of the denervation sensitivity, it can actually constrict with 2.5% methacholine or 0.1 to 5% pilocarpine. So answer will be, most cases are bilateral because most cases are unilateral. Question number 7, a patient presented with a normal eyesight. Eyesight is normal, and we have got the absence of direct as well as consensual light reflex, direct and indirect, in the same eye. So in the same eye, I am getting both absent. That means